Hello, welcome back to the Uworld study sessions. I didn't record a theme song. I don't really feel like it right now. I just kind of want to do one of them, so here I am, I'm doing it. I'll make a silly song eventually for an intro, but for now, whatever. Okay. So today it is the anatomy of the knee, and it is 26 pages, so I will probably pause in between this to take a piss break and drink water and things. So more editing for me, but probably better than just grumbling on. And there's also people upstairs, and you know how much I love that. Okay. Anyways, let's start. Okay. The knee is... Oh, and I guess the reason I picked the knee for today is because my mom needs knee surgery, so yay, busted out knee. Might as well review, right? Damn. Okay. Anyways. The knee is a hinge joint that connects the thigh and leg. It allows for flexion, extension, and limited rotation, and it supports body weight during stance and gait while providing mechanical leverage for propulsion. Its stability reflects the interplay between bone shape, meniscal contour, ligament support, and coordinated muscle action. Bone structures. The knee joint is a synovial hinge joint located between the femur, tibia, and patella. It functions as the principal articulation of the lower limb, enabling flexion, extension, and limited rotation. Major structures of the anterior and posterior knee are presented in the following figures. See Figure 1. And see Figure 2. Scrolling. Okay. Femur. The distal femur contains several important landmarks. Femoral condyles. They are two rounded prominences, medial and lateral, at the distal femur that articulate with the tibial plateau to form the main weight-bearing surfaces of the knee. Intercondylar fossa, or notch. This is a deep space between the condyles that serves as the origin for the cruciate ligaments, posteriorly, and opens anteriorly onto the patellar surface, accommodating the patella during motion. Sorry. Okay. Trochlear groove, patellar surface, or femoral sulcus. So this is the depression on the anterior distal femur that articulates with the patella. It is covered with thick hyaline cartilage and helps stabilize patellar motion, preventing excessive lateral movement during knee flexion and extension. The tibia. Key landmarks of the proximal tibia include tibial plateau, broad, flat surface that articulates with the femoral condyles. There's also the intercondylar eminence, which is a central projection formed by the medial and lateral tubercles that serves as the insertion site for the cruciate ligaments and the meniscal horns, helping to stabilize and support the femoral condyles during flexion and extension and preventing excessive antero-posterior motion. There's also lastly the tibial tuberosity, which is a bony projection on the anterior surface of the tibia that serves as the insertion site for the patellar tendon. And then we have the patella. Oh, okay. Sometimes I forget to breathe. I'm sure it's obvious to you guys. Okay. The patella is a large sesamoid bone embedded in the quadriceps tendon. It serves several functions. Mechanical advantage for knee extension. The upward glide of the patella into the trochlear groove during knee extension optimizes force transmission across the joint and improves leverage. Joint protection. Patellar position protects the joint from direct trauma and reduces friction between the quadriceps tendon and the femoral surface. Joint nourishment. Compressive forces during movement create pressure changes that circulate oxygen, glucose, and waste products around the femoral cartilage and distribute lubricating synovial fluid evenly throughout the joint. The fibula. The fibula is the slender lateral bone of the leg. It connects proximally to the tibia at the tibiofibular joint and through its entire length via the interosseous membrane, with its head positioned just below and posterior to the lateral tibial condyle. The fibula does not articulate with the femur and is not directly involved in the knee joint. It is relatively non-weight bearing, however, it serves important roles in the following: knee joint stability, where alignment of the tibia with the femur is maintained through the supportive role of the fibula. And then there's the attachment site. The fibular head provides insertion for both the lateral collateral ligament, LCL, and the biceps femoris tendon. Then there is joint structures, articular cartilage, avascular. Okay, so the articular cartilage. We're going into joint structures for articular cartilage. This is avascular slippery cartilaginous tissue covering the articular surfaces of the femoral condyles, tibial plateaus, and patellar facets. Its specialized matrix and layered structure allow low friction motion, shock absorption, and nutrient diffusion through synovial fluid. Histologically, articular cartilage consists of hyaline cartilage organized into superficial, middle, and deep zones, optimized for shear and compressive resistance. My nose is so blocked. I feel like I always feel it when I start recording these things, so, bear with me whenever I'm just, I'll try to just bend away from the mic and just clear my throat real quick. We're so professional here, right? Okay. The menisci. The medial meniscus is a C-shaped cartilage firmly attached to the tibial plateau and the medial collateral ligament, or MCL. The lateral meniscus is circular and more mobile, separated from the LCL by the popliteus tendon. Both menisci deepen the articular surfaces, improve load distribution, and assist in joint lubrication and proprioception. Histologically, the menisci are fibrocartilaginous, with peripheral vascularization and central avascularity, explaining the poor intrinsic healing of the inner meniscal tears, which is something that my mother has, and I probably have a teeny tiny one too that I should get checked out eventually, but one at a time, they don't need to know about that right now, but for my own documentation purposes, yeah, I definitely do have some fucky-wucky knees for my age. I think a lot of people tend to age their knees a bit faster than they realize, and a little tangent is just because I grew up doing Bharatanatyam, which is a type of Indian classical dance, it's known to kind of be a little hard on your knees, which is interesting because it's so good for a bunch of other things, but I think maybe in some ways because of the way certain teachers maybe emphasize certain things, you can express the dance without it being as damaging, I think, is my theory, and I'm curious to explore that at some point, because I do love that form of dance. I do like my knees as well, Same thing with running. Running is hard on your knees. I've gone over this before, I think. I think I said this before, maybe, but it's people say, running is hard on your knees, and also if you do it a lot and don't take care of yourself, there's other issues, but there's things like swimming and stuff that are a little more low impact on joints like the knee, which tend to age disproportionately, quickly, and for just a lot of people in general. Oh, by the way, I forgot to say, Partner is also studying with us on iPad. I'm staring at their purty face right now. Sorry to be gay, but okay. Alright, back to the ligaments. So yeah, we just finished up the meniscus, yeah, but my mother's knee is it's bad, and I'm hoping for the best. I will definitely probably have things to say about it in the future as we continue with the process of her getting that fixed up and stuff. Okay, ligaments. Cruciate ligaments. The cruciate ligaments, see figure 3, scrolling, well, I'll pause for a sec, and then scrolling, are strong intracapsular but extrasynovial bands of tissue that cross each other in an X configuration within the intercondylar fossa of the femur. Cruciate equals cross. So there is the anterior cruciate ligament, or ACL, which arises from the posteromedial aspect of the lateral femoral condyle and inserts into the anterior tibial plateau. It prevents anterior translation of the tibia relative to the femur during flexion and hyperextension, and excessive internal rotation of the tibia during pivoting. Then there's the posterior cruciate ligament, or PCL. This extends from the anterolateral surface of the medial femoral condyle to the posterior tibial plateau. It prevents posterior displacement of the tibia during flexion and contributes to rotational stability. Then there are the collateral ligaments. The collateral ligaments are extracapsular ligaments that enhance knee stability by resisting side-to-side angulation. They are taut during extension and more relaxed during knee flexion. There is the medial or tibial collateral ligament, also known as the MCL, which is a broad capsular ligament that extends from the medial femoral epicondyle to the medial tibial condyle, attaching to the medial meniscus. It resists valgus stress, which is force that abducts tibia relative to the femur, such as the knock-kneed position. Then there is the lateral fibular collateral ligament, or LCO, which is an extracapsular cord-like band extending from the lateral femoral epicondyle to the fibular head. It is separated from the lateral meniscus by the popliteus tendon. It resists varus stress, or force that adducts tibia relative to the femur in the bow-legged position. Then we have the posterior capsule and supporting ligaments. The posterior capsule of the knee prevents hyperextension and posterior displacement of the tibia. In addition to the PCO, it consists of the following: the oblique popliteal ligament, which originates from an expansion of the medial hamstring or semimembranosus tendon at the posteromedial aspect of the knee, running superolaterally across the posterior knee and attaching at the lateral femoral condyle. Then there's also the arcuate ligament complex. This stabilizes the posterolateral aspect of the knee. It consists of the arcuate ligament, which is a Y-shaped band from the fibular head, and the popliteus tendon, as well as the LCL. The arcuate ligament arches superomedially over the popliteus tendon and blends in with the posterior capsule, stabilizing the posterolateral corner. Then we have vessels. The popliteal artery supplies the knee through 5 genicular branches that form a circumferential anastomotic. Okay, anastomotic. Is that right? Anastomotic? Fuck, man. I think it is. Circumferential anastomotic. Like anastomoses, like, they're connected, right? So that form a circumferential anastomotic network around the patella and capsule. This network provides collateral circulation during knee flexion. Venous return parallels arterial pathways and converges into the popliteal vein. Nerves. The knee joint receives innervation from articular branches of the femoral, sciatic via the terminal tibial and common fibular peroneal nerves, and the obturator nerves. So once again, that's femoral, sciatic, and obturator. The terminal tibial and common fibular peroneal was all part of sciatic, for anyone that is not looking at the screen. That's why I keep clarifying these things, is like so that you can just listen to this, so that I can also just listen to this instead of having to see the words. But the words are there, if you need them. I won't have them for all of them in the future. I did not get to back up everything, but later problem, going through what I have first, right? Okay, these nerves form a complex plexus around the joint capsule, contributing to both sensory and proprioceptive input. There's the anterior capsule, and the femoral nerve. Okay, so the femoral... Oh, yeah, okay. Sorry. Wait. No, yeah. Yeah, okay, sorry. I was confused about this arrow, but I think I get it. Okay, anterior capsule, which has the femoral nerve. So we have the femoral nerve supplying branches to the quadriceps muscles, particularly via the nerve to the vastus medialis, and provides sensory fibers to the anterior and anteromedial aspects of the joint. Then there's the posterior capsule and popliteal fossa, where we have innervation from the tibial nerve. So the tibial nerve is formed from a terminal branch of the sciatic nerve and innervates the posterior capsule and cruciate ligaments, especially the posterior cruciate ligament, PCL. In addition, it contributes to sensation in the popliteal fossa, the superficial diamond-shaped passageway external to the posterior capsule behind the knee, where nerves and vessels pass posteriorly. See Figure 4. God, that was a mouthful. This whole thing is. All of this is. That's what she said. Okay. Popliteal fossa, you can see. So we have the tibial nerve, and then we have the common fibular nerve. They're coming off that sciatic nerve in the back. And this femoral nerve that we had for the anterior capsule is not shown back here, just to clarify. This figure is just for the second part. I feel like I don't need to clarify that. That was probably very obvious to, like, everyone else. Maybe I should take a break after this part. Yeah, I think I'll take a break before I move on to tendons and muscles, so that I can, like, refresh my yippity-da-da-doo-da, and I don't explain obvious-ass things. Because also, again, I don't think I need to explain, like, all of the figures and tables and things as I keep going, but I'm sure that there will come times where I do want to read through certain figures or tables, so I guess I'll just, follow the flow of my bussy and see where it wants to go. Okay. I hope nobody upstairs can hear me. God. Okay, lateral capsule. I could have paused that whole time over the picture, but no, I was being useless as two shits. I'm so hypercritical. Holy shit. This is therapy. Lateral capsule and meniscus, innervated by the common fibular or peroneal nerve. The peroneal nerve curves superficially around the neck of the fibula, where it is vulnerable to injury. Medial capsule, innervated by the obturator nerve. The posterior division of the obturator nerve gives an articular branch that supplies the posteromedial aspect of the knee capsule. This branch travels through the adductor canal and often accompanies the femoral artery and its descending genicular branches as it passes through the adductor hiatus to reach the knee. Because this articular branch shares segmental origins with the hip joint branch of the obturator nerve, pain from hip pathology can be referred to the medial knee. I really hope I'm saying genicular right. Every time I say it, I keep wondering. Genicular, genicular, genicular. I don't know. I want to, leave in the fact that I make mistakes, because, that's just part of life, and I think it's exposure therapy for a lot of people on the receiving end. And I'm a lazy fuck, as my uncle has joked a few times now. No, not like he didn't say lazy fuck, he just said, oh, lazy, and it was a joke, I think. I swear. He's sweet, it's fine. Okay, the shared segmental innervation of the knee explains the frequent occurrence of referred or diffuse knee pain, such as discomfort from meniscal, cruciate, or capsular injury that may radiate beyond the joint itself. And then we're going to have tendons and muscles, so we are at 9 pages. Let's see. Okay, so I will continue, and probably I might take another break, maybe after I'm done with tendons, muscles. Ooh, nice burp. I'm always going to burp into the mic. I think I've decided to do that. Everyone's got to have a thing, right? That can be my thing. That was a joke. That was sarcasm. Everyone does not have to have a thing. I don't know why I'm still scrolling. I'll decide where I want to end eventually. I'm just going to pause here for now. So, pausing here before tendons and ligaments. And I'll pick it back up in a sec, which will literally be a sec for you guys. So, ready to time travel? Ready? And time travel. Alright, I am back, and I'm gonna continue from tendons and muscles. So, quadriceps tendon. The quadriceps tendon represents the convergence of the 4 quadriceps muscles. Quad equals 4, rectus femoris, vastus medialis, vastus intermedius, and vastus lateralis. See figure 5. And that's figure 5. Okay. The tendon inserts. Wait, one sec. I'm gonna adjust the mic a bit. Okay. The tendon inserts on the base of the patella at the superior pole. Functions are enables knee extension and hip flexion for the rectus femoris. Blood supply is lateral femoral circumflex artery and deep femoral artery. The innervation is femoral nerve L2 to L4 to all four heads. Then we have the patellar tendon, or ligament. The patellar tendon represents the continuation of the quadriceps tendon distal to the patella, located from the apex of the patella to the tibial tuberosity. One sec. It's always shit in my throat. That's what she said. Okay. Functions. Transmits quadriceps force to the tibia for leg extension. Serves as the primary extensor mechanism of the knee. Blood supply. Genicular branches of the popliteal artery. Inferior medial, inferior lateral. And recurrent tibial branches of the anterior tibial artery. Innervation. No direct motor nerve function. Patellar reflex L3 to L4. There was a notification. Okay. Patellar reflex L3 to L4 tests integrity of the femoral nerve and quadriceps motor arc. Hamstrings and pes anserinus. Pes anserinus. I don't know, whatever. The hamstring consists of 3 muscles spanning the posterior thigh, including the long and short heads of the biceps femoris, inserting laterally on the fibular head. The semitendinosus and semimembranosus, both inserting at the medial tibia. The semitendinosus also contributes to pes anserinus, or goosefoot insertion, located on the medial tibia. See figure 6. Medial knee and pes anserinus. Okay. And along with the sartorius and gracilis tendons. So that whole sentence was... the semitendinosus also contributes to pes anserinus, goosefoot insertion located on the medial tibia, and along with the sartorius and gracilis tendons. Functions are assist in knee flexion and hip extension. During knee flexion, the biceps femoris also laterally rotates the tibia, whereas the semimembranosus and semitendinosus medially rotate the tibia. The pes anserinus provides dynamic medial stabilization to the knee and aids in flexion and medial rotation of the tibia. Innervation. L5 to S2, tibial division of the sciatic nerve for the semitendinosus, semimembranosus, and long head of the biceps femoris, and the common fibular head or peroneal nerve for the short head of the biceps femoris. Blood supply. Deep femoral artery, perforating branches, all 3 muscles. Inferior gluteal artery, biceps femoris, popliteal artery, semimembranosus. The pes anserinus is supplied by the medial inferior genicular artery. And before I do gastrocnemius and popliteus, I'm going to take a sip of water. I think I might be getting sick. I hope not. Though it would track, because I just hung out with a friend that was like, I might be sick and get you sick, and I was like, who cares? But... well, it would look like... okay, anyways. Gastrocnemius and popliteus. Man, I'm freaking tired. It's kind of late. It's not even that late, I'm just tired. Okay. Wait, let me sit a different way. I won't say I'm sorry, I swear. Oh, that was a good back crack. I'm definitely getting sick. Whatever. Or wait. No, maybe I am. I don't know. I should keep talking, shouldn't I? Okay. The gastrocnemius arises via 2 heads from the posterior surfaces of the lateral and medial femoral condyles and crosses the knee and ankle joints, joining the deeper soleus muscle. Function: primarily plantar flexes the ankle and assists in knee flexion. Innervation: tibial nerve S1 to S2. Blood supply: sural branches of the popliteal artery. The popliteus is a small triangular muscle originating from the lateral femoral condyle and inserting on the posterior tibia. Function: unlocks the knee by laterally rotating the femur on the fixed tibia during weight-bearing or medially rotating the tibia on the femur during non-weight-bearing flexion. During knee extension, such as standing upright, the femur is internally rotated or locked on a fixed tibia. Man, it won't go away. I'm sorry. Fuck, I said it. I said it. I'm sorry. Maybe it's just my neck. Okay, neck crack. Ooh, TMJ crack. I think it's just that hour my voice is giving out. But only half of this left, so if I really need to, maybe I'll give up and sleep on it and finish it. But I'll see what else I can get through. I don't think it sounds as bad as I'm probably worrying it sounds like. I probably just sound like congested and pubescent with my voice. The voice cracks. Okay, did I read the whole Popliteus just now? Fuck. Why was I scrolling around? I don't think I did. No, yeah, I just read this part. Okay, so innervation, I don't think I read the blood supply. Fuck, I'm all over the place. Whatever. Okay. Ooh, at least I smell like jasmines, though, because Mother gave me lots of jasmines for my hair. They smell so good. I wish you guys could smell them. It's my favorite flower. But it might be tied with, like, those hot pink roses. Those are so pretty. Okay. Innervation, tibial nerve L4 to S1. I don't think I read that part. I don't know. Blood supply, medial, inferior, genicular, and posterior tibial arteries. Okay. Bursae. So there are several bursae. Figure 7. We have here the bursae. It's from the lateral knee. Several bursae reduce friction between skin, tendons, and bone. Oh my god. Prepatellar bursa. So the prepatellar bursa is between the patella and the skin, commonly inflamed in housemaid's knee. The superficial and deep infrapatellar bursae are over and beneath the patellar tendon. The pes anserine bursa is between the pes anserinus tendons and the tibia. The popliteal or gastrocnemius semimembranosus bursa is in the popliteal fossa and may communicate with the joint cavity and form a Baker cyst when distended. Clinical correlations. Trauma to the ligaments, tendons, and associated structures. Damage to supporting structures of the knee can be acute or chronic. Holy shit. In general, acute injury is more likely to present with visible deformity, such as hemarthrosis or hemarthrosis, deformity, okay, and may predispose to future osteoarthritis or instability of the joint. Nice. In contrast, chronic damage is usually due to degenerative disease, such as arthritis. It may be asymptomatic or present with more insidious pain or intermittent mechanical symptoms, such as joint locking or catching. I have that. Okay. Anterior cruciate ligament tear, figure 8. And scrolling on. Acute injuries are caused by sudden changes in direction, excessive internal rotation, or valgus bending forces when landing from a jump. Posterior cruciate ligament injury, see figure 9. Okay. Acute injuries are caused by acute excessive posterior force to the knee, as with sports injuries or motor vehicle accidents, such as dashboard impact on knee. Collateral ligament injury, see figure 10. And then going down, acute MCL tears are more common and also associated with tears to other ligaments, such as the unhappy triad of combined ACL, MCL, and medial meniscal injury caused by a twisting force and caused by a valgus stress to a partially flexed knee. Acute LCL tears are much less common, occurring with a varus force to an extended knee, and typically in conjunction with other ligamentous injuries, such as ACL, PCL. Meniscal tears most commonly affect the medial meniscus due to its less mobile positioning and attachment to the MCL. Acute medial meniscal tears usually occur in the context of twisting with planted foot during sudden deceleration and indirection change, and direction change, and frequently involve the MCL. Chronic degenerative tears usually occur in older patients and may primarily cause dull pain or mechanical symptoms such as catching and locking. Common fibular peroneal nerve injury, see figure 11. I'm gonna grab another sip of water. I hope that every time I say I'm drinking water, I hope that whoever listens to this also drinks water. Because, like, we probably don't drink enough water. Okay, scrolling on. Injury to this structure, commonly due to compression where it wraps around the fibular head, can potentially result in foot drop and impaired toe extension due to resulting weakness of the ankle dorsiflexors and everters. Tendon rupture, quadriceps tendon and patellar tendon. See figure 12. And figure 13. I probably scrolled by that too fast. Here. Okay, and then this one. Okay. I mean, you can always pause. Okay. Quadriceps tendon rupture causes a palpable defect superior to the patella and a low-riding patella, whereas patellar tendon rupture causes a palpable defect inferior to the patella and a high-riding patella. Chronic overuse injuries. Patellofemoral pain syndrome, see figure 14. And moving on. Known as runner's knee, it is more common in women and presents with anterior knee pain. Contributing factors include overuse, malalignment, or history of previous acute injury to the knee. By convention, the pain is not due to intra-articular, or like meniscus, or peripatellar, like patellar tendon or ligament disorders. Iliotibial band syndrome, see figure 15. There it is. Kind of scrolling down a little bit more. Okay. This overuse injury is frequently seen in runners and presents with poorly localized lateral knee pain radiating to the thigh. Tendinitis. Inflammation can affect any of the tendons surrounding the knee joint. One example is patellar tendinitis, see figure 16. Okay. Which is seen commonly with activities that require frequent jumping and deceleration and presents with pain on inferior pole of the patella during tendon loading, such as jumping. I skipped that's what happened, okay. Presents with pain on the inferior pole of the patella during tendon loading, such as jumping. There we go. Okay, osteoarthritis, figure 17. Damn, we're almost done, yay! A lot of this was just pictures. I shouldn't have fret so much. We're doing it, okay. So this is what my mother's knee looks like, and what many of our knees are probably on the way to looking like if we don't take better care of it. Yeah, my mother has done a lot for me, and unfortunately her knee has taken the brunt of that. So, not in like a guilt way, but in a like, I'm very grateful for her, and it sucks that she's gonna have to deal with all this shit that I can't like stop her from dealing with, pain-wise and recovery-wise, but at least I will have the skills and knowledge to be able to help somewhat, so that makes me feel a little better, I can just be there. But yeah, okay, continuing. Osteoarthritis is caused by degeneration of articular cartilage and is characterized by joint pain, stiffness, periarticular bony enlargement, and decreased range of motion. Pain is typically on the anterior or medial knee, aggravated by weight bearing with stiffness followed by inactivity. Joint swelling and crepitus may also be present. Bursitis. Overuse injury can occur due to inflammation of the bursa, such as pes anserine bursitis, and typically presents with local pain, tenderness, and swelling over the affected bursa. Prepatellar bursitis, such as housemaid's knee or carpenter's knee, causing pain on the anterior knee, can occur with repetitive kneeling. That's what she said. Sorry, figure 18. Okay. Yeah, anyways. Baker cyst. A Baker cyst is a fluid-filled sac in the popliteal fossa that forms when synovial fluid from the knee joint extrudes into the gastrocnemius semimembranosus bursa. It typically arises due to inflammatory or degenerative joint conditions or knee injuries that increase synovial fluid production. The cyst may rupture, causing swelling and tenderness, mimicking a deep venous thrombosis. See figure 19. Owie. All of this is owie. And that was it. That was the end. Okay. So I'm gonna go ahead and end this nice, simple, sweet, because it already is run pretty long, I'm pretty sure. Yeah, I'm recording my thing. You're in my anatomy of the knee. It actually just finished. So, the end. I love you. Don't die. That's all. He went back upstairs. I paused for a sec so that I could say that. Well, don't die yet. You know, die at some point. 'Cause, like, fuck immortality, low-key. That's for another time. Bye. Good night. Get some sleep. Drink water. I'm gonna shut up now.